So we're going to start off with the case. You guys have been amazing. I can't believe you've stayed this long and you're awake and you're still here. I'm always impressed at the end of the day. But we're going to go through the case and you guys can jump in. I want it really to be interactive and ask questions. And we're going to go back and forth as we present the case, going over our strong suits. But this is a patient of mine. So I want you to be engaged and I want you to be thinking as I go through the history. I want you to be thinking, what's going on with her? Where would I go with this particular case? So 32-year-old Indian female, long-term patient of mine, comes in, I haven't seen her in like 3 or 4 years, and has been trying to conceive for a year and she's unsuccessful. Data point number 1. When she comes in visually, she looks great. I mean, she's normal BMI, small body frame, looks good to me. But she says she has more acne than she normally does. But visually to me, I can't see it, but she's noticing it right around the jawline. Her cycles are a little irregular. They used to be anywhere from 32 to 34 days. Now she can go all the way up to 60 days. And that's concerning. So she could go 60 days and then come back and have like a 34-day cycle 2 months in a row, and then it can go 60 days again. Weight gain of 15 pounds, but I really can't visually see it. And then I said, well, where is the weight going, right? So you want to know what's the body composition, because she looks great to me. She says predominantly around the middle. So her BMI is normal, but when we did a waist circumference, it's in the middle, right? So it's the visceral fat, even though she's thin on appearance. So that's really important. The first speaker in the conference said something I thought was really important that should stick with people. It's just because somebody's thin doesn't mean they're healthy, right? So don't jump to they look fine and they can't have a problem. And she's become a vegetarian. That was her first line. I've changed over my diet over the last 5 years. I've become a vegetarian. That should be neon sign number, can you hear me? That should be neon sign number 1 when they become vegetarians. What does a vegetarian mean to you? Right? Because oftentimes, when you ask them what they're eating, they're a carbitarian and not a vegetarian. And in fact, that was the case. There's nothing more unhealthy than a vegetarian that doesn't know what they're doing. And most of them don't, especially, this isn't the case, but especially my adolescent girls that come in and my college girls that come in, it's a disaster and it's a hormonal disaster. It's all over the map when they do this. They don't get enough protein, they go really high on the carbs. And that's what she was doing. It was oatmeal. Oh, I have a great diet. I'm doing oatmeal for breakfast, a vegetarian sandwich at lunch. I do a lot of rice and dal and sometimes pasta for dinner. And I do a ton of fruit. Ding, 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 right? And eats all day long. Next part of the case. Prior to ovulation, she gets bloating, but it's not bloating after eating. It's bloating associated with ovulation to her period. She has an increased craving for sugar. She has painful, heavy periods. She always had heavy periods, but now they're getting heavier and they're more painful. What are you thinking? These are the labs. She goes, I went to my GP, give you more data. Fasting glucose, he said all my labs were normal, quote unquote. Fasting glucose 99, fasting insulin not done, hemoglobin A1C 5.6, CBC completely normal, TSH 3.2, triglycerides, even though they're normal, higher quartile of normal, and her lipids were normal. So what are you thinking? At first glance, where's your mind going? Blood sugar, insulin resistance, blood sugar, yep. Okay, then we do a Dutch, because she's trying to get pregnant and we're trying to figure out what the deal is. Look at what's happening on the Dutch, right? So you have an estrogen in the normal range, you've got a progesterone that's low, and you've got a testosterone that's high. Androgens that are high, and DHEA, total androgens, are high. What are you thinking?
What's the her cycle?
6 days before her cycle. Yeah, luteal What are you thinking? Good question. What are you thinking? PCOS, right. Excellent, PCOS, right. It's a PCOS type.
What about the relationship between her estrogen and her progesterone? Go back.
Yeah, we have it right here, yep.
Yep.
So the relationship between her estrogen and progesterone, right? Just because she has a normal estradiol level doesn't mean the situation's normal. when you look at it in the luteal phase and her progesterone's running on the low end. And then again, her androgens are on the high end, elevated androgens. She has estrogen dominance in the face of normal estrogen, which is a key clinical takeaway. One of the beauties, and they talked about it before, and Mark talked about it, of this particular test is not only can you tell that their androgens are high, you can tell what pathway they're shunting them down, right? So this particular patient is shunting it more down the alpha pathway. Now, if their testosterone, I've done it on people that I had serum testosterones that were a little bit elevated, and when I did, and they were not symptomatic, and when I did the Dutch, they were going down the beta pathway. So they weren't expressing an androgenic profile. And the opposite's true. I've had people with free testosterones on the high end of normal, but not abnormal, that were getting male pattern baldness, hirsutism, and acne because they were pushing it down the alpha pathway. So understanding this pathway for me has clinical relevance when I'm looking at people trying to figure out, well, what's happening and not just looking at a testosterone by itself. So androgenic 5-alpha. And again, we drew some labs in our office that day just to kind of complete what wasn't done. And again, you look at the T4, it's normal, but could be, free T4 could be better. Free T3, normal, but I think could be better. Not bad, could be better. Hemoglobin A1C, these were done before, 5.6. Again, high end of a normal range. Fasting glucose normal, but really high end of a normal range. But for me, the big thing was this fasting insulin. If you do it on Quest, they're gonna tell you anything under 17 on a fasting insulin is normal, and that's so not true. So the first thing to change with an insulin resistance profile is 2 hours after a meal, your insulin levels are gonna spike. Before you ever see it on fasting insulin and before you ever see abnormal glucose levels. The second thing that you're gonna see is on fasting levels, your insulin's gonna be up. And for me, I like to see it closer to 5, maybe 6 at the most. So this is almost 3 times what I want it to be. Yes?
Could you repeat what you said about 2 hours after eating?
The first thing that changes with metabolic syndrome or insulin resistance is 2 hours after they eat a meal, the first marker that's going to change is their insulin levels are going to start to rise. So I didn't do a 2-hour glucose challenge. We did a fasting. So I was able to catch it because she was further progressed in the spectrum of insulin resistance where her 2-hour insulin was actually elevated.
So you like insulin at 5, is that the 2 hours post-parental?
No, that's a fasting.
Okay.
Yeah, I didn't do the 50-gram glucose load on her. I just wanted to see what was happening on her fasting, and this showed up, so I didn't need to go to that. But I know that this has been here for a couple of years, right? Because this is the second thing that changes. And then her LH-FSH ratio is normal, but high end of a normal range. So the teaching points, and Joel, do you want to go through well, Dr. Gersh did a fantastic job. But the teaching point with PCOS, and I'm repeating what she said, is that you don't have to have you don't have to have cysts on the ovaries. You have to have amenorrhea, but she doesn't have amenorrhea, oligomenorrhea, which she does have. She has fewer periods than she used to, and she has androgens trending up. So she's got 2 out of the 3. And it's a spectrum. Even if you don't have exactly the androgen markers that they want, or 4 periods in a year, if you're trending that way, you're moving on the spectrum of PCOS. So again, just like Dr. Gersh said really effectively, it's a spectrum. It's not an absolute diagnosis. So you're looking at all of the data and you're hearing what's going on. So the pathophysiology in this particular case is elevated insulin is one of the most likely drivers. It's not the cause, because the cause is probably what she's eating, combined with a genetic predisposition for her insulin resistance to show up in the ovary. So it's a combination of things. But the elevated insulin is a driver. So elevated insulin leads to improper functioning in the hypothalamus, improper production of the FSH and LH in favor of LH. And when that LH goes up, it's more androgenic, you don't ovulate. The estrogen, if you're not ovulating, you're not making progesterone from the corpus luteum. If you're not making progesterone from the corpus luteum, you're going to have more estrogen in relationship to progesterone.
So the key takeaway here is that when you start with that elevated insulin, that insulin is going to have an impact on the hypothalamus and the pituitary. So you're going to be making LH and FSH out of sync for normal ovulation, and it's going to be biased to making more LH. And remember, LH is what makes androgens. And so you're going to be starting off with insulin affecting the brain. The brain then tells the ovary to make more androgen. And that's the source of the androgen-related symptoms, and it's the source of the lack of ovulation, and it's the source of not enough progesterone, and the source of why you have a relative estrogen excess.
Yep. And so elevated insulin, again, you know, what we're thinking about is we're thinking about things in a network, right? So how do things link together and cause other things? So understanding the relationship of how things affect things, that an elevated insulin also decreases sex hormone binding globulin. So if you decrease sex hormone binding globulin, again, you're going to have more free estrogen, you're going to have more testosterone around. It also alters, as Joel was saying, alters the enzyme in the ovary, the theca cell, and so the theca cell is making more androgens, which increases testosterone, which further decreases more testosterone, lower sex hormone binding globulin.
So this just really continues to add to this story, because not only do you have the brain signaling the ovary to make more androgen, but you have changes in the ovary because insulin acts not just on the brain, but also directly in the ovary. And so the insulin acting in the ovary causes it to make more androgen. And what does insulin do to sex hormone binding globulin? It reduces it, so you'll have more free androgen. What does this elevated androgen do to sex hormone binding globulin? It reduces it, so you'll have more free androgen. So this is, everything becomes additive. Starts in the hypothalamus, and then you have direct effect on the ovary.
Right. And so in genetically susceptible individuals, so this is a piece of information you didn't know. Her mom had type 2 diabetes, and her dad, although not diagnosed, had the weight gain in the middle, skinny but weight gain in the middle, right? Genetic predisposition. So again, we're going to show it, you know, first it was step by step, and people that like graphs, elevated insulin gives you abnormal hypothalamus pituitary response of LH and FSH. You get anovulation. You get an increased testosterone produced by the theca cells of the ovary. That's going to increase insulin, and increased insulin gives you increased testosterone. It's bidirectional. Then you get less of the sex hormone binding globulin, so you get more free testosterone, more free estrogen. And the beat goes on. And you can see how everything is related to everything else here, that it's a feedback loop. So here's another way of looking at it. We just put multiple ways because people learn. Some people learn in lines. I don't. I learn in pictures. Some people are great with graphs. So this is just another graph showing the same thing, how insulin in genetically susceptible people can play out and create this PCOS profile. And again, PCOS is a spectrum. It's not an absolute. That's why it's hard for a lot of people to diagnose. They can diagnose it when it's overt, but it's hard to diagnose when it's really subtle. That's where the testing really helps. And then, again, what you're thinking about, we're going to go into the gut, and Dr. Gersh talked about this really nicely, but here's a paper on how the gut microbiome really impacts PCOS. So those lipopolysaccharides and the dysbiosis in the gut then create an inflammation and an immune system activation that impacts insulin receptor function. So again, what's going on in the gut is impacting what's going on in the ovary. So when you see people with PCOS, you don't just target lowering the androgens or just target lowering the insulin. You're looking for where's the inflammation, right? So you're looking at all those things. And then you want to take a deeper dive into the testing. So we're going to talk about estrogen metabolism, but Dr. Rogan, can you stand up for a second? Because she is the pioneer. So I almost wish I could hand you the microphone. She's the pioneer of estrogen metabolism. It has transformed the way we practice. I just want to acknowledge you for everything you have done. You've transformed our practice and what we do and how we test and how we think about things. So this is her work I'm talking about. This is not my work or my observations. So the other thing that's really valuable on the Dutch test and why I like it is because you can get all this information in one place. You can see what's going on with the estrogen, progesterone, testosterone ratios. You can see what's going on with the androgen and what pathways they're going down. But then you can actually take a deeper dive into the estrogen and look at estrogen metabolism. So estrogen metabolism, can you hear me? Did I lose you? Estrogen metabolism, if you think of estrogen as an 18-carbon pearl necklace. So when we say estrogen metabolism, we're talking about how does the liver in phase 1 and phase 2 detoxify estrogen. So it does it in, I'm going to say 3 ways, right? 3 places. So 18-carbon pearl necklace. First pass of the liver, what you have to do is put a hydroxyl group on the 2nd pearl, the 4th pearl, or the 16th pearl. It's genetically driven, but it's modifiable if you know what's happening. So the 2 is actually protective, but you always want things in balance and in a ratio. The 4 is associated with dangerous quinones, and that's an increase in the CYP1B1. If you have that type of a SNP, you're going to have a propensity genetically to make more of the 4. That's a dangerous quinone that could damage DNA, that can be associated with an increase in breast cancer. And if you go down and put the hydroxyl group on the 16th pearl, it's actually can cause, I think it's a little bit more inflammatory in nature, but Dr. Rogan, you can comment on that, Rogan. And it has a propensity to cause other problems. So it's a bad actor. 4 is the really bad actor, 16 also not so good, and 2 is more protective. So you want to understand what's happening with the metabolites because it's going to be part of your treatment plan. So the way you look at this test visually is you start by looking at the pie chart.
So if you look at the 2, it's coming in at 59.1%. And you could just look at it visually. You want it to be 80% of the pie chart. You don't want it to be 100% of the pie chart because then you're going to have other problems. But you want it to be closer to 80% of the pie chart. Then you look at the 4, which is in the red. Now the 4, it's a little over range. I typically like it to be closer to 5 to 7%, but here it's 11.8%. So she has a propensity for this upregulation of the 1B1, but the 16, which is also problematic in different ways, is coming in at 29%, and we really want that down to 13. So just visually you're looking at it, and you can just look at the 2 and realize it's not close to the 80% mark, and then see that there's a problem going on. So problem in the first phase, in the hydroxylation phase. After it's hydroxylated and it becomes a reactive intermediate, which is more damaging than the molecule was to begin with, then second pass of the liver, you have to put a methyl group on it so that you can move it out in stool or urine. And there can be 2 issues with methylation. You can have an issue with the COMT enzyme. The enzyme that puts the methyl group on can be sluggish. Or you can have an issue with MTHFR, either 1 copy, 2 copies of the C677T or 1298, depending on what's going on. But this test gives you an idea. It doesn't tell you you have COMT. It doesn't tell you you have MTHFR. But actually, I need my hand to be able to click.
But before you click, what I would say is, do carbotarians get a lot of folic acid in their diet? Right? Because folic acid comes from green leafies.
Good point. And also, when you look at her methylation, I don't know if she has SNPs, but I would say this is not bad, but could be much better. So methylation is on your radar screen. And then the third part of the equation, you can have a problem phase 1, problem phase 2, then it's got to move to the gut. If you've got dysbiosis in the gut where you're producing that beta-glucuronidase, you're going to cleave off the estrogen and recirculate it back into the system. So there can be problem in multiple points, but when you look at the testing, you get a good idea of where you want to go clinically without ever doing any of the genetic testing. Detox genomics they're great, but they're expensive. MTHFR a lot of times won't be covered by Quest. COMT absolutely is not covered. So just economically speaking, on this one test, you've got a really good idea of where to go clinically. You want to change her 4, you want to change her 16, you want to change her estrogen metabolism, and you want to increase methylation. So on the Dutch results, what we know so far is that there's low progesterone metabolites, there's high estrogen in relationship to progesterone, there's an altered estrogen metabolism with more of the 16 and a little bit more of the 4 than I want to see, and the 4 is a dangerous quinone. The androgens are trending high, and the androgens are more androgenic because they're going down the alpha pathway. And so we're suspecting PCOS, and again, PCOS is in a spectrum. So what you think about clinically, or what goes through my mind, how I think about it is, okay, how do I normalize her insulin and glucose levels? How do I decrease her stress? Because there was, how do I go back on this? I got to show you something I missed that is a clinical point way back here. Hang on. Too many things. Oh, well, I'm just going to go forward because I can't find it. When we looked at her cortisol pattern was fairly normal during the day, and at about 5 o'clock at night, it starts trending up. So there's something going on in the 5 o'clock slot. Okay, so let's get back to where we were. Okay, how do I decrease her stress? Because her pattern is fairly good during the day, and I'll show you it a little bit later. But then at night, she has an inverted pattern. She's spiking up. And how do I decrease inflammation? So I think you've heard this from every single speaker, that inflammation is the pivot point of every single chronic disease. Just is. And in this particular scenario with PCOS, inflammation is a really bad actor and plays an important role in the dysfunction you see, and the metabolic dysfunction you see with PCOS. So understanding where the inflammation is an important thing. So inflammation increases insulin, again, links, and insulin increases inflammation. And so once you get in that loop, you go down that whole loop that we were talking about before that leads to abnormalities in the hypothalamus and abnormalities in the ovary and anovulation. So treatment plan: normalize insulin, decrease inflammation, enhance ovulation, and look at what's going on our HPA axis.
And wait, just go back.
Okay.
Because you now understand that decreasing inflammation will help you to normalize insulin and glucose, right? So our line, and Monique always says to me, well, you know, if we're talking about a case and I say what I think the cause is, she goes, well, what's the cause behind the cause? And so when we're talking about PCOS, and you heard us start with elevated insulin, then the question that you all have to figure out is, what's the cause behind the cause? Why do we have the elevated insulin? And so what we're just trying to show you now is that one of the reasons might be inflammation, right? So. And
so when you think about inflammation, just an easy place to start is what are people eating, right? So we interact with food 200 times a day. So every interaction with food is an opportunity to turn off inflammation or to turn on inflammation and oxidative stress. The other key point is every time we eat, even if it's kale, there's a certain level of inflammation and oxidative stress that happens with digestion and assimilation. So Dr. Gerst was talking about this yesterday, is that intermittent fasting and time-restricted eating, and I do it all the time with my patients, I love it, is a really great therapeutic strategy to begin to lower inflammation, oxidative stress, and normalize insulin levels. So we put her on a low glycemic index food plan, you know, increasing vegetables, decreasing carbohydrates. And then we also did something called a food intolerance test, where we found out what she's sensitive to. And of course, you know, there's her high sensitivities, but she's sensitive to, you know, it was like 15 different foods. So again, it's not that she's really sensitive to 15 different foods. You can glean from that, especially since those are foods that she was eating commonly, that she has this intestinal permeability going on, even without knowing what her lipopolysaccharides were, right? Again, clinically just thinking, what can I tell from this? How can I save the patient some money and streamline what I'm doing and not just over-test them? So I took her off the top foods she was sensitive to, and then we did time-restricted eating or feeding, and I love it. And so that means going a longer time from dinner to breakfast. In even patients, and I know Dr. Gersh said this, but I want to repeat it, even patients that don't change the amount of calories, when you change the time they're eating, it can unlock it and help them begin to lose weight. So she stopped eating at 7 o'clock at night, and she began first starting with 12 hours, because that's all she could do. So what can you start with? I can go from 7 to 7, and then slowly increase it to 13 hours, and then slowly increase it to 14 hours. So after 12 to 13 hours, you've gone through all the glucose in the bloodstream, you've gone through the 50 grams of glucose in the liver, and then and only then will you switch over the beta oxidation to burning fat for fuel. So if you're always feeding yourself, you're not going to get into the fat cells for particular genotypes. So just beginning to move them, and at the 16-hour mark, it's pay dirt. They're really beginning to change over the beta oxidation and burn glucose for fuel, and it helps normalize those insulin levels, helps them lose weight, and it decreases inflammation and oxidative stress, turns on the antioxidant response element, and upregulates detoxification pathways. So it's a great, easy, cheap intervention to begin to do with people, but people that are metabolically unstable, you can't throw them in the deep end of the pool and have them start by fasting 3 days in a row or even fasting once a week. Start with doing 12 hours, and slowly, as we did with her, we slowly increased it. Yes?
So you're going to sleep for 8 hours, you're going to fast for 12 hours. Do you want the 4 hours to be at the end of the day or at the beginning of the day?
So
In other words, are you going to hold off eating breakfast, or are you going to eat dinner early?
I give them a choice. So what she wanted to do, she's not as hungry in the morning. So she chose not to eat breakfast and to have a lunch and a dinner, and then finish her dinner by 7 o'clock and then not eat again until the lunchtime. That's a good question.
Although if we look at the literature here, it's slightly better to eat earlier and finish earlier than to start later and finish later. So, but the significance, the delta of the benefit of that isn't all that much.
Yeah. So Bethany, that's a great question. And again, this is where the conversation comes in. What was really important to the patient is that she has dinner with her husband, right? She doesn't care about breakfast. She's on her way to work. He's not even home. But she doesn't want to give up the ritual of the evening meal. So I flip it based on what's going on, because I don't want to ruin the family dynamic and the energy of that. So that's important to me to figure it out. So this is where we started. But that's a great question, because ideally.
What I care about is not getting hypoglycemic in the middle of the night and waking up.
Yeah, that's why you do it. That's why you do it when people are metabolically unstable. You do it very slowly, and you do it back and forth based on what they can tolerate. So she started with 12 hours in the morning and then worked up to 16. But that's a really good point. That's why we personalize the recommendations for people. You don't throw them in the deep end of the pool, because if they become hypoglycemic in the middle of the night, you're causing more of a cortisol surge, and you're causing more inflammation and oxidative stress by doing the fasting. So you've got to fast with wisdom and look at the situation. So love it. Appreciate it, Bethany. Fish oils, again, fish oils across the board, decreasing inflammation, but also for cell membrane fluidity and flexibility, because she's got insulin resistance. So the membranes, you want to make sure that the membranes are responding to signals. So the phospholipid layer in the cell membrane, if you change it by fish oils, even though she's a vegetarian, because she's looking to get pregnant, she was okay with taking fish oils in this particular instance, because I explained to her the purpose: decreasing inflammation, changing cell membrane receptivity to insulin. And then we did vitamin D. It's an anti-inflammatory, hormone signaling molecule, helps with tight junctions of the gut. Gave her a protein powder with glutamine, aloe, and all types of great gut repair and branched chain amino, so I'm increasing her amino acid status. I gave her things, insinase, dioxanol, and a probiotic. Those are products that actually help with insulin and glucose regulation. Then for stress management, because on her curve, her cortisol was going up in the evening slot. And so I asked her, why is your cortisol going up in the evening slot? What's going on with you in the evening slot? And she goes, well, during the day, I'm really busy at work, and I was assessing her stress. Great relationship with her husband, great relationship with her friends. Finances are stable, but they're looking to buy a house, but her finances are stable. Loves her job, no problem. During the day, she's really busy at a job she loves, and she doesn't feel particularly stressed. When she comes home at night and she relaxes, she starts thinking about the what. She's a what-if person. Well, what if this happens? What if that happens? What if this happens? So her habitualized mind, so it's not external stress, it's internal dialogue. So her habitualized mind is to go to the worst possible case scenario in every instance and start worrying and thinking, what if, what if, what if? But this plays itself out in the evening slot. So I asked her what she wants to do, and mantra meditation is something that speaks to her. I didn't prescribe it. It speaks to her. So when she walks in the door, because it starts going up, her cortisol at 5 p.m., she did 5 minutes. That's where she wanted to start. She didn't do 20 minutes. She didn't do mindfulness meditation. She wanted to start with 5 minutes. That was doable to her when she walked in the door, just to reset and get her in a mindset where she can begin to examine the habitualized mind. And then we used her thoughts as a biofeedback device, okay? So every time you start thinking, what if this, what if that, you notice that it's happening, connect back to your breath, and just begin to work in rewiring the habitualized patterns that you've created and put in something positive. I wasn't going to tell her what to put in, but put in just a different message or a different word. So beginning to change patterns of thinking as a way to lower that evening cortisol. And then walking, I have no time, I'm busy, I'm too tired when I get home, all that kind of stuff with exercise. But, I let them go through, because people will go through all the reasons why they can't do what it is that they know they should do, that you're asking them if they can do. And then so I let her do all that. I validated the fact that she's incredibly busy and it's tough to add it in. She's tired at night. And then I said, well, what do you think you can do? Like, can you do it anywhere, even 5 minutes, 10 minutes? And then she said, yeah, I can do 15 minutes at work. So again, these are your starting points to get people moving in the right direction. Because movement begets movement, begets movement, begets movement. So no matter how small the change, any change is going to be moving people in the right direction. And once they have success, they keep going with it. So from the results of the Dutch test, I love Vitex or Chaseberry, and I always do it in the morning. I do 500 in the morning to kind of reset that luteal pattern and begin to help them with ovulation. I do DIM or Indo-3-carbinol to improve estrogen metabolism. I love, there's a liquid glutathione that I use. I started with 5 milliliters. We did a methyl B complex and myo-inositol, which I love for insulin resistance with PCOS. This is a home run product. So myo-inositol, just keep it on your screen for the insulin resistance PCOS person. So it improves the ovaries' response to insulin and glucose, and it actually enhances the maturation of the follicle, so enhances ovulation combined with the Vitex. So it's just a good combination. I always do 2 grams BID in a powder. It's got a little magnesium glycinate in it. So we were tracking her with the goal of, at the 6-month mark, repeating her labs just to see where she was. But she was coming in every week. She was following along. She was doing great. She was increasing her fasting time, slowly losing. She came in at 7 months instead of 6 months because she was in the middle of buying a house. I really wanted her to repeat the Dutch test, but at that point, only because she was buying a house, she wanted to wait on the economics, and things were improving. Her acne was greatly improved, but not totally gone. She had lost 12 pounds, and the weight was mostly in the visceral area. So her body comp changed. More than her weight changed, the body comp changed. Remember, the visceral fat is hot fat. It's inflammatory. So we're lowering inflammation by that. Her cycles were becoming more regular. Her periods were still heavy, but they were improving. The pain was improving. Her fasting insulin was really dramatically changed. And then her hemoglobin A1C was now even better, even more improved over the 7-month follow-up. So then, we have a plan. We're going to repeat Dutch testing and look at all of her hormones in a couple months. But she comes back in 10 months, and she said, I'm not getting my period anymore. Like something's gone incredibly wrong. Or has it? So lack of ovulation, not getting your period doesn't always mean there's pathophysiology. Could mean there's a baby. Thank you. Any questions you guys have for us? Yes. Yes, I do. And this is how I do it, and I don't know how you do it, but I do it the entire month, and I always do it all in the morning. That's what and it takes about 3 months to kick in, so don't give up on it. And I tell people that it takes 3 months, and then it starts, the cycles start normalizing for people.
And sometimes I'll double up in the second half of the cycle. So it's always every day. And then if we're getting some relief, but we haven't reached goal or target, in that second half of the cycle, I'll double up. Also in the morning. So I don't go to a BID, I go to a double dose in the morning.
So the big takeaway really is just listening to the patient, and this is the beauty really of the Dutch test, is you can get all that information even without the genes on one test, and you know where to go clinically. I'm all about clinical utility and decreasing the cost for the patient and having me be able to figure things out. And so on one test, I can figure this out with some labs from Quest. So that's, beautiful thing. All right. Bethany.
When in this picture would you add in either looking at or emphasizing detoxification? Looking at, products and food, organic food and
Yep.
maybe even looking at heavy metals
Yep.
in somebody who's trying to get pregnant.
Yep. Right in the beginning. I mean, I didn't go through all the stuff that I did, but that's a conversation. And we had her on prenatals because she was trying to conceive. There were some other things to this case. So we had her on prenatals, and we always talk about in the beginning, we like to do 28-day detoxes or elimination food plans when they're beginning to get pregnant. So it's something with someone who's trying to conceive that you want to do before they conceive. You want to think about detoxification, you want to think about food sensitivities, you want to think about putting them on a prenatal.
And the other thing is husband's methylation. You want to say something about that?
No, but you can if you want. I didn't even think about the husband's methylation, so jump in.
Well, male epigenetics determines placental.
Do you want this, Bethany? Here, stand up.
Female epigenetics is about the growth of the embryo, but male epigenetics is about the growth of the placenta. So a lot of early pregnancy losses are placental, and if the husband is not methylating, his epigenetics is not going to function properly. So I always pay attention to not only the epigenetics or the methylation of the mother, but also make sure that the husband is tested for MTHFR and is on B vitamins.
All right. Anything, thank you, Bethany. Anything else?
Just one more question, so we make sure we can get Dr. Evans' patient.
Sure.
Yeah, is the estrogen dominance independent of the PCOS? You don't always see that with PCOS, do you?
Yes, you do.
You do.
Yeah, but it's not estrogen dominance in this case like she was making too much estrogen. It's more estrogen in relationship to progesterone, right? Because she's not ovulating. So it's a relationship issue and not an absolute high.
I'd just like to make that people understand that, just like what you said, that in general, there's a lot of data that women with PCOS have an aromatization problem. So they inherently make less estradiol, but the degree is very variable. That's why in some women it can measure in the reference range, but it may be too low for what it should be at that stage of the cycle. So it's an estrogen dominance only related to the progesterone. They're not making more estradiol. A lot of people think that women with PCOS are making more, but they're not actually making more. They tend to make less. The only other comment that was great, by the way, is that the data on Chase Tree says for women, the small percentage that has elevated DHA sulfate, it actually lowers the DHA sulfate.
Awesome.
That's about 13%, but it's a very unique group, and they're really hard to treat. So for that unique group, the Chase Tree is particularly good.
Thank you so much. And your book is fabulous, by the way, and we appreciate your lecture.
Okay.
Okay. Oh, we got lots of waters there.
Here, I'll give you this,
Okay.
and you give me that. All righty. So now we're talking about that woman that we started to talk about yesterday before we ran out of time. And this is someone who's 51. She's got symptomatic fibroids, so pelvic pain, heavy periods, and a strong family history of breast cancer. And she really came in and just said, I need help. I want help. I'm, really a mess. And she's still cycling at 51, and she's very concerned about her risk of breast cancer. Her mother was diagnosed with early stage at age 78, and she's seeing this in her friend group. So her friends, not just her parent, her mom, but her friends are starting to get diagnosed with breast cancer, and she's Ashkenazi Jewish, and she's scared. So she's had these fibroids causing problems for 4 years, and she's also been told her blood sugars have been borderline for the last few years, and she has been given a diagnosis of being pre-diabetic and told she needs to lose weight, and then isn't seen again for a year. She's had dense sprints on mammograms for many, many years. Her last mammogram was recent, normal 2 months ago, dense, normal ultrasound. She had BRCA testing, which was negative. Now, she wouldn't have met criteria for BRCA testing through the old criteria. Now they just have revised BRCA testing criteria about 3 or 4 weeks ago. But she wouldn't have met criteria, but because she was anxious, she chose to be tested and was negative. And she had a cardio CRP of 4.6. And though 3 is normal. So first of all, when you're doing cardio, when you're doing measuring C-reactive protein, I hope all of you are measuring either highly selective or cardio CRP. They mean the same thing. Don't do the standard CRP test. So the cardio CRP is 4.6. The normal is up to 3. So you might say normal's up to 3, this is 4.6, this isn't so bad. This is bad, right? This is really inflamed. I really want my patients to be lower than 2, but really less than 1. But up to 2 is okay. So she was only having bowel movements 3 times a week. We talked about this. So now you're not surprised that this is my patient, right? From what I said yesterday. So she's only having bowel movements 3 times a week, but she occasionally has intermittent diarrhea and gas shortly after eating. So what does that mean? It means there's something going on in her gut. We don't know exactly what it is, but there's something going on in her gut. And one of the things that's probably going on is inflammation. One of the things that's probably going on is dysbiosis. One of the things that's probably going on is she's not eliminating her estrogen well, certainly because of the decreased transit time, so that estrogen that's in the stool is going to be reabsorbed. And because of the dysbiosis, it's likely that the bacteria are going to be making that enzyme called beta-glucuronidase. And that enzyme, what it does is it separates the estrogen from the glucuronide molecule so it can be reabsorbed. So this is what we're starting to think right now just from here. And now we see the joint aches, especially in the knees. Well, that's one of the sources of inflammation. So if we're looking at this from the focus of breast and fibroid, we know now that we've got 2 sources of inflammation that are flooding her body with pro-inflammatory cytokines, her joints, her knees, and her gut. Now, of course, as her doctor, I want to make her feel better, so I want to help her with her digestive symptoms and with her knees. And what's nice is that whatever I decide to do, whether identifying the foods that cause inflammation, whether giving anti-inflammatory nutraceuticals, whether they be pure herbals, whether they be fish oil, whether they be pro-resolving mediators, whatever we decide to do, it's going to help both the symptomatic gut issue, the symptomatic joint issue, and it's also going to help with fibroids because, as I showed you, inflammation, specifically prostaglandin E2, a pro-inflammatory cytokine, stimulates aromatase in the fibroid to grow and produce estrogen, and does the same thing in the breast. So this is how we address her issue of breast cancer, her fear. That's her fear. I always want to address your patient's fears. That's one of our jobs, right, as a doctor, is to find out not just what they're coming in for, but what are their fears, so we can let them know that we're addressing them. So we're addressing, here she was very upfront about her fear, right? So this is how we can address her fear and at the same time address her symptomatic issues. And then she's under stress, finances, marriage, children going to college. So she's got really the three legs of the stress stool, as I like to say: money, spouse, and children, right? And there is no quick fix for that. But what there is an understanding of, I have to start working on this stuff. And how do we find the right person to help your patient? I think one of the most important things anybody that's interested in being a good functional medicine doctor and working on hormones is to have a bunch of really good therapists to refer to. You need to have a lot of cards in your Rolodex. And I got to tell you, and I know this happens to you because we've talked about it, but there are therapists now that are understanding about the brain-gut connection and are looking for functional medicine doctors to send their patients to. And so I'm seeing referrals from therapists to say, do whatever you do, wave your functional medicine wand so I can be a better therapist and help my patient with their issues. Are you seeing that?
Yep.
Yeah. So, so that's something that's very important. The elevated BMI, the elevated blood pressure, and again, this issue with dysglycemia and a little bit of anemia. So I pretty much talked about what we know, but just, why don't you guys just parrot it back? So what do we know so far about this patient? Inflammation. What else? Stress. Blood sugar. Right. And dysbiosis. And she's close to being menopausal. And so everything, this is the perfect storm, because she's got this strong family history of breast cancer and she's overweight. And we talked about breast cancer being increased in women that have a family history, that's obvious. Being overweight, yes, but also having elevated blood sugar and insulin resistance. She's estrogen dominant. I know this before I do my Dutch test because she's got dense breasts, fibroids, and heavy periods. Now, what the Dutch test will tell me is if there's too much estrogen relative to progesterone, in which case I'm going to be working on the liver to enhance excretion versus where she is on her menopausal transition and it's normal estrogen and just low progesterone. So that's where the test will help you because it guides your therapy. It guides your therapy. She's inflamed and her gut is out of whack. And she's under stress. So I would say that if we took whatever percentage, whatever number of midlife women that you guys see in your practice, I would say at least 80% have 2 or 3 of these issues, right? If not more. And now you see the importance of addressing it and why it's important to do this test to see if this estrogen excess relative to progesterone is high estrogen and you really have to hit the liver hard and hit the gut hard, or whether it's just a matter of this low progesterone. That's such an important clinical differentiation. And then she's a little bit anemic from her heavy bleeding. So she's at increased risk of breast cancer because she's got the family history, because she's overweight, she's got the insulin resistance, she's estrogen dominant, she's inflamed, and her gut is out of balance and inflamed. And she's under stress. These are the women that get breast cancer. It doesn't mean women that don't have this don't get breast cancer, but this is the classic. And now you understand the hormonal imbalances as to why. So because this is an estrogen dominant concern, the framework is to decrease estrogen intake and estrogen formation and increase estrogen elimination. And we know, again, based on the Dutch test, which part of this pathway we push harder. So organic, whole foods without hormones or xenoestrogens. Flaxseed. Now, the thing about flaxseed is raw flaxseed, eaten whole, so someone buys flaxseed at Whole Foods, puts their spoon in and throws it on their chia, isn't going to do anything. Flaxseed has to be ground, and it has to be ground immediately. So you need to have a dedicated coffee grinder, put in a tablespoon of raw, and then when you turn on that coffee grinder, the flaxseed will increase in volume, so it'll be much more than a tablespoon after it's ground. So it's not a tablespoon of flaxseed that's been ground, it's a tablespoon of unground flaxseed, which is then ground. It's an aromatase inhibitor, and it's fiber, which helps get rid of the estrogen in the gut. Probiotic and a healthy gut to decrease beta-glucuronidase, 5-hour program. Eliminate constipation. Natural aromatase inhibitors like green tea. Detox nutrients, again pushing the liver, artichoke, green tea, watercress, milk thistle. Think about detox SNPs for methylation, estrogen metabolism, and adjusting the diet and supplements as needed. Eat the rainbow every day. We want all of our phytonutrients. Really eliminate refined sugar, cruciferous vegetables for estrogen metabolism, and herbs and spices, ginger and turmeric, green tea, organic non-GMO soy, reduced caloric intake, and the website I like with a lot of these good recommendations is keepabreast.org. So let's look at what the cycle mapping showed. So remember, when you look at these tests, the black is the border, and you want your tests to come out in the black. So the estrogens are on the top, and you can see that certainly towards the end of the cycle, they're elevated. And then you look at progesterone on the bottom, and it's low. And is there ovulation? Not really clear. But definitely, this is not an estrogen-progesterone imbalance where estrogen is normal. This is an estrogen imbalance or estrogen-progesterone imbalance where we have both elevated estrogen and low progesterone. So it's both. Now, the estrogen metabolites are taken on day 21, but if we just did a single day 21 shot and not a cycle map, we'd miss this beautiful example of estrogen dominance and estrogen excess. So here we see progesterone a little bit on the lowish side, but okay. And then here, as we're looking at the estrogen and we're comparing the pie chart, it's not that pie chart that we want. So here we have someone who's concerned about breast cancer. We have to fix the way she is taking care of her estrogens. So there's the genetic piece to this, but as you know, it's all modifiable. So we can modify and improve and make more 2 and less 16 with flax, with soy, with physical exercise, cruciferous vegetables, indole 3-carbinol, diindole methane. And then you can see that methylation is off as well. So we have to work on methylation. Reduce inflammation, reduce stress. Stress is pro-inflammatory. Normalize body weight. Remember, people that are overweight have less SHBG. Less SHBG is more free hormone. That leads to more free estrogen. So normalize blood sugar and insulin. Insulin lowers SHBG. Elimination diet or food sensitivity testing to identify the dietary sources of inflammation, because her gut is inflamed. Her gut is behaving badly. And test for MTHFR and COMT, and again, normalize that estrogen metabolism.